all over Oregon. Sweet. All right, folks. Well, thank you so much for being here. This meeting is being recorded for future sharing for those who could not attend. Closed captioning is available. You can find them at the bottom of your screen. Um, I'm Ashley. I'm part of a team of graduate students partnering with Healthcare for All Oregon to provide two educational webinars designed to kind of ground Oregon's movement towards universal healthcare in lived experience and shared values. Our topic tonight is going to be on street medicine and the future of care. During the second week of March, we will also be hosting another webinar. It's called Faith in Action, Values that Guide the Future of Healthcare. So please keep an eye out for information about that. I'm going to hand it off for a minute to Colin from HCAO. He's going to tell you a little bit about Healthcare for All organization who we partnered with.
Thanks, Ashley. Yep, my name's Colin Stackhouse, and I am a contractor that works with HCAO. I'm do our communications. My title is Communications Coordinator. So for those of you who may be new to hearing about us, HCAO is a 501c3 nonprofit organization that educates people around the state about, and we advocate for equitable, affordable, comprehensive, high quality, publicly funded universal healthcare. So we are advocates for universal healthcare reform, close to a single payer system, which means one entity that covers all the costs and compensates all the providers as we can get is what we want. We think that a single payer system will improve the lives of individuals, families, and communities across Oregon and throughout the United States. We have offered several educational webinars over the past few months that are available for you to see on our YouTube channel. Deep dive into how Taiwan's system works, a deep dive into how the VA healthcare could benefit from a transition to single payer. And those are available at our YouTube. I'll drop that in the chat. We're here tonight to keep building out this education, and we are so grateful and pleased that these PSU students were able to work with us for this webinar. So thanks for being here, everyone.
Thanks, Colin. Yeah, so we're really excited. We have a fantastic panel tonight. We are joined by Amanda, a community health worker in Eugene, and an MSW student in our team that's partnering with HCAO. We have Theresa, a Lane County rural outreach worker, and Trevecca, a licensed clinical social worker and medical social worker in Eugene. So I want to start by kind of grounding us in what we're going to be talking about tonight. So street medicine is the practice of delivering healthcare directly to people experiencing homelessness across a continuum. So that could be conditions such as living outdoors in parks or on sidewalks, to people staying in shelters, vehicles, or other places not meant for habitation, as well as those who are in couch surfing in temporary housing or transitioning into more stable housing. All three panelists will help inform a really engaging conversation about how community shows up and ways that street medicine and mobile clinics can really prove that people-centered care is possible. So we won't be able to cover everything related to this topic tonight. I wish we could talk forever, but instead this conversation is going to be more of an introductory discussion from service providers, providing us a baseline understanding of what street medicine looks like in practice, as well as what it can teach us about delivering care with respect and dignity. I think this is also an invitation for us to all think about the aspects that should be taken into account as Oregon designs our own state-based universal healthcare system. We're going to have dedicated time at the end of our panel for questions. However, you're totally welcome to chat, drop comments in the chat, reactions and questions as we go. We've got another MSW student, Joel, moderating our chat, and we're going to work to ensure all your questions are answered. Kelsey is another student partner who will be checking the webinars email, so please email webinars@hcao.org if you run into any challenges tonight or have any questions during our time together. So yeah, excited to be here. Let's dive into our conversation. So to start us off, let's maybe talk about, panelists, who you are, the type of work you do, and how you came into this type of community work. Amanda, maybe you could start us off, and then we can go to Theresa and Trevecca.
Yeah. Hi, everyone. I appreciate you all being here from all over the United States, which is really cool. My name's Amanda, and I'm a community health worker. I've been providing outreach and case management services in the Eugene area for 10 years. And for those of you new to the definition, I just wanted to share a community health worker is a frontline public health worker who is a trusted member of and or has a close understanding of the community served. The relationship enables the worker to serve as a liaison, link, or intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. So, really, folks who are able to go out on the street or meet with people where they're at and help them navigate things, help advocate for them. Some folks have lived experience. I personally do not, but have spent a long time doing it. I've experienced working with medical respite shelters and housing programs with coordinated entry and street outreach for frequent users of the hospital. And I'm one of the Master of Social Work candidates here at Portland State. The reason I'm here today is to amplify stories from the humans I've had the privilege of working with. And homelessness is a continuum. I just want to kind of talk about the people we mentioned today are multifaceted and complex, not bad people who made bad decisions or anything like that. Humans, these are all humans who have families, who work hard, who cope in similar ways to any group of people. They're not victims, but they are people who have been victimized by oppressive and systemic forces. So, to me, community is everything. It's how we support and look out for one another. We can listen and learn about the community served and also create community amongst providers to help support program participants. Thank
Awesome. Thanks, Amanda. Can we pass it over to Theresa?
Thanks, Amanda. That was really well said. Is my volume okay, folks? I see a lot of thumbs up. That's good. My name is Theresa Burchell. I work with Lane County. I am the Rural Street Outreach Program service provider at the moment. I'm the only one. And although our work is housing focused, I think it is centered in harm reduction. And harm reduction is access to housing, access to medical care, access to harm reduction supplies if you need. It's a wide variety of things, access to food, clean water, bathrooms. What drew me to this work is I have over 10 years experience in the social service world, whether it's working in shelters back home in Wisconsin or working with institutionalized youth in Montana. And also even working here at shelter care back when diversion program was in its extreme infancy. But I saw the posting for this position and I envisioned an opportunity to perhaps develop work that was trauma informed and reduced barriers and created a harm reduction workflow in which I could utilize my access to services and systems in order to bridge the very real and serious gaps that our community members experience while trying to access services.
I don't know if Trevecca's here right now. I think we might have lost her.
She is.
Oh,
That's her iPhone down.
Can you guys see me and hear me?
awesome. Hey.
Okay. So I'm just gonna kind of speak to street medicine at its best. Like I just got out of a decon shower because I just did a visit that was not very sanitary. So I apologize. My hair is a mess and everything right now. I tried to get presentable in about 5 minutes for this meeting. So I'm a licensed clinical social worker. I work at Peace Health Riverbend Emergency Department. I've been there at Peace Health almost 13 years. worked Cahoots many years. I help lead the Egan Springfield Warming Centers for quite a few years now, and I've done hospice almost 18 years. So I feel like I'm just kind of in the trenches in all of it, and all of those avenues and different healthcare systems very much intertwine. I think I'm very passionate about it because I feel like healthcare should not be a barrier to people like being healthy and people surviving and literally living. And we see people lose their lives over like diabetes and like all these different things. And so I'm very, very passionate about it and trying to figure it out. And like we're seeing as a system right now, community wide, more and more cuts like left and right. And how do we just make healthcare accessible for people? So I know Dr. Foster, I think, is in the audience right now. I do a lot of partnering with him. He is also a Peace Health physician, but also runs Occupy Medical. And so we do a lot of stuff together. Amanda was a community health worker that I worked with for many years. So I'm super supporting her getting her MSW, and like big kudos to her. But yeah, just like super interested in how as a community we can come together better and get people healthier and not have so many barriers to healthcare.
That was awesome. Thank you so much, everybody, for being here. I really appreciate it. And I really appreciate you keeping it real. We're all humans. I think that was actually a really great segue to kind of explore, what's going on? Like, what are these barriers to care or the access inequities that this population faces? Amanda, maybe you could start us off again and we'll kind of follow that same rhythm.
Yeah, I have some notes, and again, this is a much bigger conversation than we have time for. The barriers are vast, but a few that I wanted to highlight is distrust of the system. People fear being judged for their appearance if they don't have access to water, clean clothes. They have medical records that might show substance use or mental health diagnoses. And a lot of time people have just been let down by these systems. So why would going to the doctor be different this time? There's also difficulty keeping appointments. Tracking days and time is challenging enough, but try setting up transportation when you don't know where you're going to be on the day of the scheduled appointment if they can get you in, soon. And where will you keep the written instructions from the doctor's office, where they'll be safe and dry? Soon you're getting banned from clinics for too many no-shows, and now you're afraid to even try to go to a new doctor. Like, this is a very real scenario. Health literacy is another one. If you are unhoused, you really only have the capacity to worry about where you're going to get your next meal, where you're going to sleep that night. There isn't extra brain space for the importance of follow-up for your diagnoses or where that follow-up exists. And that's kind of a problem for future you when people kick it down the road. In general, no one leaves homelessness without trauma, whether it be physical trauma from laying on the concrete, emotional trauma from not knowing where you'll sleep that night, or how long your friend's going to let you stay on their couch. And then we add in the trauma of being treated like someone who's just at the doctor's office to get drugs. And to be clear, if somebody is trying to get drugs, it's probably because they're not properly medicated for physical and or mental health. Um, yeah, this is why it's important to listen to people. I think that's like, if I can leave you anything to take away with, please just listen to people who are going through this, who are living in it. They are the experts in their lives. Trauma-informed, patient-centered care is a big need. Street medicine clinics can be an accessible way for unhoused people to get care. It doesn't require the planning or logistics. It's thoughtful to the needs of the community, and it does help people get well. And Theresa, I'd love to hear what you have to say from your rural outreach.
I'm over here like, yeah, totally. Yeah, yeah. Yes to the points you're making. I agree with you. Discrimination and prejudice is alive and well in our medical service provision for our unhoused community members. Folks we work with in rural spaces report it all the time. We experience it with them in real time in clinics, being turned away or just not being heard and being dismissed, their concerns being dismissed. And it totally, it reinforces that mistrust of medical systems and medical service providers. And, that creates this like inability to address your medical needs before things snowball and turn into like bigger medical issues, right? The preventative care piece can be difficult to address with things that, like what you're saying, where, if you don't have transportation or know how to get to places, you may not have a telephone. Maybe your camp is getting swept. Maybe you had an appointment and then all of your stuff is just completely, your life is upended, whether that's engagement with law enforcement or public works. It's very hard. It's a full time and a half job being unhoused, let alone being unhoused with medical vulnerabilities and trying to get those needs met. In rural spaces, that's where I exist. There tends to be a lack of availability in medical service provision. That has somewhat decreased that unavailability in recent years. Orchid Health Clinic, which Dr. Foster was a part of, in Elmira. But they have a few locations in Oak Ridge, Elmira, Blue River, and a lot of our folks are seen there. But a lot of our folks still use emergency room as their primary care providers because that covers a few things, right? It covers transportation. You're going to be seen somewhat immediately. You don't have to make an appointment and then go back. And so having street medicine it's bringing that doctor's appointment right to them. You're eliminating the barriers of transportation. You're eliminating some of the barriers of schedule keeping because you're going to show up and you're going to be consistent and you're going to provide those services for them. And you're going to provide everything you possibly can in that moment so that they don't have to go to another location to get their needs met, unless perhaps it's a prescription. And then perhaps you're also going to support them in getting those needs met too. We don't see a lot of street medicine in rural spaces, but we do see some street medicine here in the Eugene Springfield area, thanks to Occupy Medical, Black Thistle Street Aid, Daisy Chain, people who are going out there and bringing that service provision to folks who really understand that's what really has to be done to meet people where they're at. That's one of the most trauma-informed things that we can be doing is meeting people where they're at and removing the expectation for human beings, right? We're all human beings. We're complex. We have all sorts of things going on. Removing that expectation for folks to travel out of their rural space into another town or area they may or may not be comfortable or familiar with and expect them to communicate their needs efficiently, to be able to advocate for themselves aggressively, because that is what you have to do to get your medical needs met, housed or unhoused, and to do the follow-up care. Street medicine provides so much to folks who are unhoused, especially in rural spaces, and I'd love to see that work expand outside of the metro area. There's always going to be a need for it.
Trevecca, we're going to pass it to you.
Hi. So I would agree that I feel like the lack of availability for primary care and outside services, primarily home health, particularly wound care, creates a lot of visits in the emergency department that are not emergency department visits, right? So we have 57 beds technically in our emergency department, and daily right now we're averaging 20 to 38 plus beds, like we call them borders, where they should be in inpatient beds upstairs, but we just don't have the staffing or the beds available. A lot of those patients are mental health patients, so we're really struggling since the closure of University District. We don't have the capacity for mental health patients in the same way that UD did. Because when patients are suicidal, they're homicidal, they're meth, like, intoxicated and all the things, we can't leave them in the lobby. So they tend to get priority over medical patients. But we absolutely, especially with OMG closing and like 3,000 plus people losing primary care doctors, like we just don't have the capacity to get people into clinics. And so I feel like a lot of our emergency department visits could be primary care, urgent care visits, but people just come, they need med refills, they need wound care. So we're absolutely at critical capacity at every single day. And so we're always trying to come up with very creative solutions on how to get people care.
Thank you so much, you all. I really appreciate you describing how your experiences as service providers, you know, impact your knowledge of these areas and how you're able to identify all of these kind of barriers to care and access inequities, and also see like the needs of your community, and like the need for trauma-informed care. Um, so kind of thinking about like you talked about using hospitals a lot, emergency rooms, how those are being really relied on, and some of those kind of unique challenges that rural communities face. Now that we kind of know what the access barriers are, what kind of resources are available in your community? And then maybe if, those aren't immediately available, what are kind of those things that you dream of that you would love to be available in your community?
I can definitely speak to that. So I would say for our unsheltered population in this community, Dr. Foster is probably my number one go-to. So somebody say, we're putting at a pallet, we're putting at dusk to dawn, we're putting somewhere anywhere in the community that we can try to get a bed, and they need wound care or something, but they don't have a primary care doctor, and you have to have a primary care doctor to get like home health wound care. So Dr. Foster is phenomenal at being willing to see those patients, go do visits with them. I wish there was like 900 more of him in our community. Um, Also, I think there's a huge need for, like, I'm really excited and hope this mental health facility that Peace Health is partnering with and will hopefully be up soon would free up a lot of beds in our emergency department, would be fabulous, so that we can really focus on the more critically medically needing patients that need to be cared for. And I just think there's the biggest need is primary care. Like we need primary care doctors left and right. Like every single day I'm battling, somebody needs a neurologist follow-up, they need a cardiology follow-up, they need this, they need that. And those providers won't follow them because they don't have a primary care doctor. So with OMG closing and then the huge surplus, like we already had a crisis and then it just exploded. But I think there's a huge, incredible need. I wish we had like 10,000 primary care doctors right now so that people could get care. I think it would decompress our emergency department. And it's really hard because I see people like that don't come in, don't come in, don't come in, don't come in. And then they come in and now we're admitting them maybe to our ICU because they didn't come in because they needed a primary care doctor to prescribe a blood pressure medication a year ago, right? So things have gotten so medically out of control. I just think we're seeing sicker and sicker and sicker patients that if we had primary care and people felt like they could go and get access to care and have supportive care, that they wouldn't end up dying in our hospital, in our community. It's pretty devastating. I think our emergency department and our hospital is more critical right now than it ever was during the heat of COVID.
Thank you so much, Trevecca.
Oh,
That is wild. Yeah, I personally didn't know anything about all of that, and how that impacts this community. So I really, really appreciate you with all that insight. Amanda, Teresa, anything that you'd like to add to this conversation?
I'll jump in. Trevecca, spot on, absolutely spot on. Yeah, the lack of emergent mental health service provision in the Eugene Springfield area, let alone anywhere else in Lane County, has been devastating. The fact that the city of Eugene continues to not have an emergency room, completely wild. Yeah, I can't imagine what it is like to contend every day with such an influx of need for folks. And you're right, no one's out there doing it like Dr. Foster and Black Thistle Street Aid and all the homies who are doing it on the street level. No one's out there doing it like they're doing it because it takes so much grit and dedication and continuing to show up for incredibly vulnerable folks who are dealing with complex things. It's not just medical stuff, there's mental health stuff. There's all sorts of stuff of things going on in people's lives and they're experiencing. And these folks are showing up for them, straight to them, bringing them that medical care, the wound care, so that people can build themselves up healthier and continue to exist in our societies. Like I said, what's available in rural spaces besides emergency services? We've got the Orchid Health clinics in a few of our locations. Florence obviously has Peace Health, which does have an emergency room, walk-in clinic. They do wound care there. There are a number of specialty services there. But again, there are a number of folks who have had very difficult experiences with that specific system. So they may not desire to go there in that area. What do we need? We need more mobile medical services on top of mobile crisis response, which the county has worked to stand up. But a couple of vans responsible for the whole county is not enough. It's never enough. Kind of piggybacking on what Trevecca is saying, the numbers need to be really huge with the number of people, of professionals that we have available to respond to people's needs. But where are the dollars to match that need? It's like it doesn't equal out. And so who suffers? The people in need suffer in the end. Yeah, so I'd love to see a mass rollout of street medicine, mobile clinics in rural spaces. I'd love to see emergency departments, more clinics going up that can welcome folks of all walks and have primary care service provision. Also looking forward to the stabilization center when that should open, but we're in an emergent situation now. So even though we're talking about what is available, the reality is yeah, we're in that emergent situation now. So we're all just like trying to hold down the fort and do what we can right now to get people their needs met.
Yeah, I would have one more thing to add that I echo everything you say. So I do 2 full-time jobs. I do the emergency department and then I do hospice. And I think also a growing need that I'm seeing is we have younger and younger people that we're admitting to hospice, and whether it's substance abuse related or heart failure. Like today I was struggling with a guy with his diabetes over 600 and very simple human, and he's not using substances, but he just doesn't manage it. And like I'm managing hospice patients in shelter settings. So whether it's Everyone Village or Dust at Dawn, we have to have them somewhere so that the nurse can go see them and me, the social worker, can go see them. And they are like my heart, my core of what I love doing. And I think one of the most frustrating things to me is we try to get people on Medicaid long-term care benefits and they don't qualify. All these people qualify financially because they don't have income other than maybe minimal Social Security, but they are still like ambulatory, right? So physically, the second part of that assessment is they have to be like pretty decapacitated physically. And when we often get these people on hospice, they're still like walking and like able to toilet themselves and like I have one guy that's riding a bicycle around town, but he has terminal cancer, like stage 4 cancer, head to toe. And so because he's still physically able to do a thing, I can't get him on Medicaid to have a funding source for a placement. Um, so then what happens is when they eventually become like, I can't walk anymore, I'm now bedbound and need total care, they end up back in my emergency department. And then I'm trying to do an emergent like Medicaid intake, which still can take time. And so then they're still taking up a bed in the emergency department for days, maybe a couple weeks sometimes. And so that's incredibly frustrating. I'm like, we know you're terminal. We know you might be riding a bike right now, but in a week, you probably aren't gonna be. And then it just like, it's this cycle of they just like end up back in the emergency department. And then we're trying to do a thing emergently. And in the big scheme of things, I feel like that costs the state and the system more money in the long run. Like if we could just, we know you're terminal, we know you're dying. Why can't we get you on Medicaid long-term care funding immediately so that when you hit that point and you can't ride your bicycle around town or be walking and taking care of yourself in whatever shelter we have you in, that I can immediately just place you into a nursing facility? It just feels like it costs the system way more money backwards. Like it doesn't make sense to me. So that would be my other fix of the system.
I'd love to also add a few things. I love what all of you are saying. Also, shout out Dr. Foster. He has helped us so much on the streets, signing orders and seeing people and coming out to them, and seeing folks that occupy. Wound care has been talked about a lot, and that's one of the biggest things that we're dealing with out there is folks are not able to keep their wound clean and dry. How would they? So they do so much good work. Also, Black Thistle, shout out to them too. Actually, we had a resident in our housing program who put them down as their emergency contact because it was just like his only connection. And I think I mean, it's kind of sad, but it's really beautiful too that like this was a support for people and these are supports for people. And I think one we're missing when we talk about this too is cahoots, because we don't have cahoots in Eugene anymore. And we do have mobile crisis through the county. However, cahoots had medics and we're not getting that wound care. And a lot of people, that was their form of going to the doctor. They would call these medics and it wasn't tying up emergency services, and they were able to come out and be dealt with, and we don't have that, and that's a big need. But yeah, we've talked about a lot of those things. I think like in my perfect world, we we would definitely have more care providers meeting the community where they're at. We need low barrier trauma informed care. We need street medicine providers, and I would advocate for more community health workers to meet with people, help them navigate these systems, who can accompany individuals to appointments so they feel more comfortable, and in general be a support person in their corner. Like if you feel like the world is against you, it would be meaningful to have someone just to help you sort through and manage things. And I think that brings up another important point, just that we talk about this situation as it's removed from us, but it could be any one of us in need. And, things like accessibility benefits everybody, like more access to healthcare, more Medicaid services, more primary care. Like that's only going to benefit everybody in the community. So I think that is just kind of a no-brainer. Also, I wanted to bring up cross-agency collaboration, like a comprehensive system to make sure we don't lose people in care gaps, especially like talking about rural. Like I think there's so few providers that those folks get lost, and people here in Eugene in the city get lost too. Like a lot of my work as a community health worker was just going out to somebody and I had a phone and we could call the system that they were supposed to be hooked up with and just like piecing together the puzzle. But we are losing those, like my position was cut. We're losing those positions. We're losing crisis response just more and more in the county. Like that's an issue too. Um, yeah. Dr. Foster, I'd love to hear what you have to say.
Oh, now you can hear me. Yeah, there's quite a few people on this call. I'm very impressed that there's 67 people from across the U.S. Just a couple of comments. One thing I put in the chat is one reason that I've been doing this for 15 years is because I'm doing it outside the system. You know, it's a Occupy Medical. We have very little money, so it doesn't really matter if we don't have any money, we're still doing it. Over the years, and this might be true in your communities, we will see a number of different organizations get a grant, stand something up for a year. The grant goes away and the street medicine program they had goes away. But Occupy Medical and Black Thistle have been doing this for years. Yeah, we get a few grants, but a lot of it is volunteer, which limits how much we can do because we can't do it full time. But they're being, volunteer. Yeah, we do get some grant money. That is one thing. Another thing I would mention that was just brought up is interconnectedness. We all thought the electronic medical record was going to solve everything, that we could see everything. And I can tell you that I couldn't do half of what I do on the street if I wasn't working for Peace Health and had access to Epic on my phone. But that's only showing me the medical part. I would love to have a platform. And you think with as much as we have with social media and AI, that there would be a platform where I could find out who their caseworker was, who their housing person was, and connect stuff as I'm out there. So the housing person sees them and goes, oh, that wound doesn't look good. Let me reach out to Occupy, send us a message. I've heard talk about this at different meetings, both locally and nationally and internationally, but it's still not there to have one system that would allow us to really address all these patients' needs. I know all of you are working in different spaces. I would just encourage you to do this. I will tell you that I get far more people telling me thank you for what I do when I'm out at one of my street medicine clinics than I do in the emergency department. Those are rare and far between in the emergency department where I work. But on the street, I tell you, every time people go, it's amazing you're out here, and thank us. And many of these people on the street we've known for years, and they have become friends. I will say that. So that's my two little bits.
That was awesome. Thank you, everybody, and Dr. Foster for jumping in there. So much context, and definitely I feel like there's a recurring theme of what trauma-informed care absolutely does not look like, and as well as what it does look like. Making folks be so completely incapacitated before they're able to access care. There is no dignity in that. That is definitely not trauma-informed care. And it sounds like some of these, systems that you have down there are working outside the system, with community supporting community through volunteering. And that's so awesome. So kind of now that we've talked about, the barriers to care, what resources there are, what resources you would like there to be, I think it would be really awesome for us to keep doing some more of that futures thinking. So if you all could kind of talk about how universal health care could impact your community and the work you do together, I would love to hear it.
I can start. I do think universal health coverage could make such a great difference in this work. Trevecca brought up like Medicaid services, getting people care, and that has been a really big thing in the work is there's this huge gap between like qualifying for care and like decompensating. And like you're saying, Ashley, there's no dignity with that. We hear a lot like, if they get worse, call us back. And also the huge gap between qualifying for Medicaid and being able to pay for private pay, which is like people in homes can't afford that. So I think that's really good. And even just this week, I've had 3 different people I work with tell me they couldn't afford their copays for medication. Like with everything else going on, with all somebody is dealing with, trying to get well, wondering how you're going to pay for your meds is just we should not have to worry about that, especially in such a developed nation. Like it's really crazy to me that healthcare has become such a business. Like it feels really like not ethical to say, give us your money and you can live longer, you can have these services, but you have to pay for them or you have to qualify for them. I just think that's really not okay for anybody. But given other barriers people are up against, it's just such a disservice to the community to then make them pay out of pocket for medications on top of everything we're already harming. I mean, and I think I did just want to, I meant to highlight again, like, I think mental health as street medicine could be really helpful. I know that was brought up a bit. But I think I feel really passionate about that because I feel like we're harming people by not giving them those services. And then by saying, well, they just presented in psychosis, so I don't know, we're just gonna let them you know, manage that with no follow-up care. And the longer you're in psychosis, the more inflammation builds up in your brain. Like this is irreversible damage. And I'm not saying there's an easy fix for all that, but we don't have the resources. And then like talking about informed consent in medical care, like I don't know what people are able to consent to sometimes when their mental health is so poor. And it doesn't need to be like that. Like a lot of times it's just that they don't have the supports or like the ability to get their meds and then not lose them, or it's a lot of little pieces. And I think I will summarize and just say we need more community. Like that is the missing piece, that like connection, that network. That's what I'd love to see. I just think it would be, I think universal health coverage is great and like the big answer, but I think it'd be irresponsible to ignore the other pieces. So just to add that.
I agree with you, Amanda. I think it's important to highlight the needs of mental health service provision. There's such an othering of like mental health. Mental health is into your physical health. It's all in this meat suit, right? Everything, all of this is getting taken care of. But universal health care, it can provide consistent service provision. It can help cover gaps that our most vulnerable community members experience when trying to receive healthcare or mental health care. It can help. It can help potentially sourcing funding for the needs of communities. So, like what Dr. Foster was talking about, how, Occupy Medical, Black Thistle Street, it's all volunteer based. Perhaps universal health care could offer funding for those types of programs. We have to look at it from both sides too, though, right? I mean, are we examining like the ethics of that? Is there a governing body that is then telling you what you can and cannot do? So, I mean, there are kinks to work out there. But I think it would be a great opportunity to return agency to folks in their and autonomy in their decision making for their medical needs. It could potentially increase employment opportunities for service providers. So perhaps it's that funding gap again, to hopefully meet, the need, although we need more people going to nursing school. We need more folks going and becoming QMHAs and QMHPs and counselors and therapists and things like that too. So we all need to be working on our own ability to provide better service provision in the future too. I'm really interested in the possibilities of what universal health care could provide. Perhaps it creates this marriage of systems information, like what Dr. Foster is saying, so that we can help support the physical and mental health needs along with the health related social needs to create a cohesive service provision for folks to make sure that people have a solid foundation to build off of. We all need that, housed or unhoused, but more so folks who are more vulnerable and have less privilege and access than we do. I'd like to see, oh, I'm so sorry. Go ahead, Trevecca, please.
Oh no, I hear you on the unhoused, housed part. I feel like I see like this huge gap of middle class people or blue collar folks that are housed but like don't have insurance. Like I can't tell you how many like loggers, truck driver accidents we see in the ED. Like really like loggers, like oh my God, their jobs are insane. And we see so many terrible accidents and none of them have health insurance. Like it's insane to me because they're like blue collar workers, they're like making decent money, but they can't afford health insurance and none of their employers offer it. And I just recently had this like personal loss in my life, this elderly man that was 30 years older than me, African American man, didn't know how to read, insulin dependent diabetic, and I love blues music. So I met him at a blues jam. And when he died, Dr. Foster actually helped come clean out his apartment for me, and we donated everything to the mission. But he like so he made when he died, he made $1,332 on Social Security. So he didn't qualify for Oregon Health Plan. They said he was over income. I actually appealed and went in person to a hearing in Salem, and they were like, the state views Medicare and Medicaid as the same. And I was like, but it's not the same. It doesn't cover his copays. He doesn't have dental. Like he has vision issues because he had a stroke in his eye from his diabetes. Like it's not that it's clearly Medicare and Medicaid are not the same, right? So I went to this hearing. Turned us down left and right. For 8 years, I paid $500 to $600 out of my own pocket because I just absolutely fell in love with this guy. You guys, he was like my whole human outside of my kids. But like, he wouldn't have gotten his insulin if I wasn't paying for it. Like, he wouldn't have gotten his heart meds. And like, so like, I just think like, obviously I have this huge love. I help lead the Egan Springfield Warming Centers, Cahoots, like a huge love for unsheltered. But for me, it's even bigger than that. We're like missing this gap on either working middle class people or these elderly people that their Social Security, because of their age, puts them out of Medicaid eligibility. And we see people that end up in the hospital because they're like, I need this heart med, or I need this insulin, or I need this, whatever it might be, this med that costs like $12 a month or something, but I can't get it because I have to pay my rent. And so to me, it's bigger than unsheltered versus like just untreated folks, or sorry, unsheltered folks, but like our healthcare system is just missing the boat on so many gaps of people that the system, like, because then I got him on the Bridges program. So then Peace Health is like paying whatever his Medicare didn't. And I'm like, in the long run, this costs more to the system than if they would have just put him on Oregon Health Plan. Like, so it just like, there's so much of it that just feels so backwards to me, where we are like, literally just our system is putting up every barrier and blockage for people to get healthcare in a proactive manner that would make them healthier humans. And instead, we're treating them on the side of them dying. And I don't like that is infuriating to me. Like I struggle to my core with that. If that makes sense at all to anybody. It's frustrating.
Yes, it does make sense.
Like we're just so reactive and like everything is about, saving dimes on the dollar. And I'm just like, if we were doing things a little bit different, like the system would be saving billions of dollars and people would be healthier. And our system isn't doing that. We're setting people up to die. And it's absolutely infuriating to me as a social worker.
1,000% agree with everything you're saying, Trevecca. I can only speak from my experience with working with unhoused folks, but what a great example of a huge gap that could potentially be helped in coverage with universal health care with that access. You're totally right. There are these um, dangerous jobs out there in the world, like loggers who are putting their life on the line, so to speak, every day. You never know what's going to happen, and they are without coverage, and their families are without coverage. 1,000%. There are so many folks that could benefit from it. I would also like to see some continued or increased service provision for our veterans. There are a lot of veterans who don't want to access the VA for, a whole host of other reasons. Um, there are a lot of veterans who deal with transportation issues just with distrust in systems and things like that. It'd be cool to see mobile medics, mobile clinics going to those vulnerable community members in our society. And that's it. That's all I got to say on that. I'm going to pass it back to Trevecca if you got anything else, because you were hitting home runs on that one.
Oh God, I could speak for days, you guys. I have big feelings about stuff. I just think, I guess, bottom line for me is I feel like our system is doing it ass backwards. And like we could be saving billions of dollars and getting people healthier if people had access to healthcare. If there was people like Dr. Foster out there doing a thing and we had primary care doctors, if people had access to pay their $12 copays versus do I buy toilet paper or do I pay my rent or my electricity, and it's huge, 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 not just unsheltered. I mean, that's obviously a huge issue in itself and that I have big love for, but it's also this big gap of people in the middle that are elderly and like working class and like we just make it impossible. Our system makes it impossible for people to access healthcare, like affordably and proactively to keep themselves healthier. And so I feel like so much of what we see in the hospital is like, oh, if you would have been on this med and like, oh, you did come in 2 years ago and we told you to start this med. And I actually met with you 2 years ago. And like, how are you going to do a thing? And then they never took the med because they can't afford the copay for the med or like, and to me, it might be like, seem like, oh, that's like, $20 or whatever, but that's like their light bill. Like, it contributes to where do I put money elsewhere? I have kids and all these things. And so it's just like, it is like, most people that know me know I have really giant feelings and I get very passionate about things. And it is the most infuriating thing in the world to me that we allow people to like, I can't get wound care. So instead, you're going to get admitted to Riverbend 3, 4, 5, 6 times. Every time you come in, we're going to amputate more of your feet off, your toes. And then we're just going to street you again and know that you're not getting wound care, even though that's what we told you to do in your discharge plan. And they're not getting it. And then they come back in and then Peace Health is eating the bill or the state is eating the bill. They don't have Oregon Health Plan. And we're causing harm to people. And that's like really hard for my heart, I guess. Like that's what I just wish we could fix it. That's all.
This is Dr. Foster again. One thing that I would encourage all of you out there with whatever group you're working with is try to bring in younger people to see this. When Occupy first started, a lot of our volunteers were middle-aged or retired. Right now, outside of the providers and nurses, which are a handful, all of our volunteers are pre-med students. And as I say, I'm trying to corrupt them early to a different view of medicine. So I would encourage all of you, with whatever group you're working with, find students that you can bring alongside you so that they see different.
Yeah, that's awesome, everybody. It's great to be here with so many passionate folks that are just so insightful about the topic. And obviously, we've touched on so many different things, even in just this question, the inefficiencies, the cost, the complexity, these kind of like concepts of who is deserving, but also finding possibilities and hope is so important. Um, we've reached the portion where we are at our Q&A. I saw Becky's hand up, so I want to throw it over to Becky if you have a question for us.
Hi, everyone. My name is Becky Blackhawk. I've been a public health nurse for 20 years. I formerly worked in Los Angeles on Skid Row, working with a lot of houseless and unhoused folks living on the street there. That's been my background for a super long time. I now work up here in Astoria with our only county mental health contractor, Clatsop Behavioral Healthcare. We recently concluded a street medicine grant. That was a 2-year grant we received from a large health system that I will not name at this time. But I was wondering about some of the challenges, if anyone else has had this problem, because it was a huge challenge for us with this. We were so happy to get the grant. We had a street medicine nurse and a provider, an MD, who was very committed to the work. We did all the things. We really had trouble with metrics reporting. Because this large health system wanted such exacting metrics, trying to convey to them that this is a population that's very difficult to extract metrics from. Many people will not give us their names. Many people don't know their social security number. Many people don't have homes or zip codes, or some don't know their age. Some don't know. And these were all the metrics that this grant foundation people wanted in order for us to maintain our reporting. And it was really, it's like they wouldn't take no for an answer. They wouldn't take any answer I had for them. I kept having to leave the reporting fields blank or write not applicable. And then I would write in the narrative why. And it would they acted like they didn't believe me. So we ended up not getting that grant renewed. And I really believe that's probably why, is because they probably had AI bots analyzing their grant reporting, and none of our answers satisfied the metrics. And so I know it's kind of a nitpicky, weird thing, but I think we're becoming so data informed and metrics heavy, especially in grant work, that when we're dealing with street populations, has anyone else run into this? And how do you combat this or deal with it? Because I'd sure like to get us another one of these grants, but the reporting is nearly impossible.
I don't have like a practical answer, and I think Dr. Foster might chime in after this, but I just appreciate you bringing that up, Becky, because I feel like those are so many important things. And then, like Valdez is saying in the chat, value-based care, those are things that, like, there's so much we can't measure that we're affecting when we are working in street health care, like people feeling safe and people getting connected to services, like people getting onto wait lists, people, like, it's not just are they healthy now, but maybe one of their wounds healed. Maybe they said, wow, I just feel like I can come here and tell you guys what's really wrong with me. Or like, I feel like I want to use less substances because somebody cares about me. Like, those are the important things too that this does that we don't measure. And I feel very passionate about that. Like, we are affecting change even when it's not in the numbers.
Dr. Foster here, I think Amanda lost her job with Peace Health because we weren't having good metrics to show how much she was doing a few years back, if I remember correctly, was part of it. And, everybody was aware of that. And you're right, collecting metrics is hard. If you have enough volunteers and they can develop enough trust and can sit down for a long time, you might be able to get some data out versus just filling out this 20-page thing at the start of your visit. But that takes a lot of time to do that, to build trust where you can get the information you need. But it is sad about, we have these fantastic stories, but sometimes stories aren't enough. It needs to be hard data.
I second what Dr. Foster is saying. In our work, it's a lot of rapport building, and that brings about those metrics and the data. I mean, I'm going to throw this out there. Creating a rapport with your grant provider. Our current funding for this fiscal year and our previous fiscal year funding is through Oregon Community Health Council, or Lane County Health Council, excuse me, I got that wrong. Lane County Health Council. And so one of the things that we do quarterly, we do a quarterly report. So they take like our metrics, like all of our data, they run all of our numbers, but we also write, I'm told to write a few sentences. I write a page, let me tell you. I'm telling you all about the successes and the work that we're doing that are not going to be reflected on like the data side of things, because like what Amanda is saying, so much of it is just not data driven. It's human centered. It's showing up. It's being the service provider that's outside of trying to figure out what the hell their social security number is and X, Y, and Z, right? So that could be some kind of angle, appealing to the human side of these funders of like, this is the reality of our work.
Oh, I
And
work with the narrative. Trust me. I
believe you
filled
on
those
that.
narrative boxes with novels of
Girl,
success
I know you're
stories
doing
and
your
like
best.
pulling on those heartstrings. And, I
Totally.
really, but at the end of the day, to the bean counters, they want,
Oh,
this
all numbers.
hard numbers. And it's becoming more and more pervasive. That is in these, in the nonprofit space, especially. And that's I work for a nonprofit. So it's just it's a very, I'm reading the comments and thank you for all the support. It was really sad when they decided not to renew the grant. And it just, because every single quarterly report was just numbers, metrics, demographics. And I'm like, they want to do is to identify how many females, males, and then by race. And I'm like, what? Like, I don't know how, like, there's no way. We're not going to sit down and grill these people about their gender identity and their race when they've got a stage 4 wound on their, their tibia showing through a stage 4 wound. I'm not going to do that.
No.
So it was just really difficult. And I know I sound probably really, I'm like you, I'm very passionate. And it broke my heart that they would not, I hope the narratives were effective in some way, but we didn't get renewed. And so there goes our straight medicine program.
It calls for radical system changes at that point.
Yeah.
You know what I mean? Like, we can only do what we can do. We're doing the work that is expected of us. We can't create this data out of nowhere. I mean, we could, but we're not going to. So that's a call for systems changes. And that's a bigger conversation. That's hard work. And that takes a lot of time. That happens over time, and the consistent pushback of like, what service providers can take this money and provide the metrics that you're looking for? Give me that answer. Bring those questions to the table. I empathize with you, because what an incredible opportunity to bring that service to people, to be taken away based on just numbers. That's unfortunate. I hope that the systems do change. I hope that our narratives continue to sway decision making. That's all I can do is hope.
Yeah, I appreciate you, Becky, and bringing all that up, because Dr. Foster is not wrong. My position was cut, and I think a big part of that was that there were not metrics being reported. But I used to keep my own metrics, and I used to write down things people would tell me, and they would tell me things like, I feel like I can talk to you, or I just needed someone to talk to. I've been using drugs less. I was able to go to the store today. Like, those are the things that are real human stories. And those affect people's quality of life. Like the metric can't be did they get housed when we are doing outreach, because but those things also happen, but the rapport takes time. Like nobody's wound heals overnight, nobody gets housed overnight, but we were out there building rapport, working with people, month after month, losing them for a while, picking back up with them, and like we were seeing those things eventually happening. And I think 76% of people I worked with while I was there did go into some kind of permanent long-term housing solution. But that took so long that I don't think there were any good metrics to really back that up. And I don't know if anyone was keeping them or reporting them but me. So I learned my lesson there.
Nobody was keeping track of anything. You're amazing. I'll agree with what Dr. Fester said. Like you were like my right hand person, and I am sorely missing you. I will tell you that.
I appreciate that. I'll pass it to Valdez. I see your hand.
Hey everybody, my name is Valdez Bravo. He, him, his pronouns. President of Healthcare for All Oregon. So thank you, Team PSU, for organizing this amazing webinar. Thanks to our awesome panelists and moderator, and thanks to all of you for tuning in. By day, even though I'm here as a HCAO guy, not as a county employee, by day I work at Multnomah County Health Department, and I just want to say on the low barrier side, I love that our behavioral health resource center downtown. You walk in, you give a name. Is it your name? It's a name. You give a name, and that's about all it is. And then we're off and running and working to support you in whatever we can. So low barrier. A lot of that we're funding out of our county general fund. So we're not dependent on grantors to give us the latitude and stuff. But I love that kind of model. The thing I was going to ask you all, our panelists, are so many times working at the county, the big innovations, the big collaborations, the big wins are if only we had a system, a gizmo, a gadget, an app to like make it so we could connect and see where people are and take this highly fragmented health system where people receive care at local level, state level, county level, federal, all these different institutions. We could just like see everyone's care all together. And then it's like we're spiking the football if we can just do a little bit of that. Like that's like the win. Like we've created a decoder ring to be able to see how this person is engaging in care across the system, even though it's not really a system. I just imagine like in a universal healthcare model, if there's like one system like Taiwan where you bust out your card and it's got your last 6 primary care visits, it's got your pulse on there, it's got your organ donor stuff, it's got your blood type, it's got all the things you need. And anyone where you go, you can see, where you've been and like what your medical history is. And it would just like, what a world that would be. I was just wondering for folks that do frontline street medicine, like if we had that simplified system where it's not only a single payer, but a single like ecosystem where everyone's clinical charts and stuff were, like, what would that like make your work significantly easier? Or is it always just gonna, maybe that's like less of the challenge for folks doing street medicine? I'm just kind of curious because I haven't done street medicine.
No, that's one of the hugest barriers, echoing what Dr. Foster was saying. Before University District closed, they started a it's called Friendly Faces meeting, and it's like all these community partners. There's like 50, 60 agencies there. And the number one complaint was we're all charting in different systems. So like I could be doing a thing with someone, an Alliance might be doing a thing, or Homes for Good or SDS, and none of us can see what each other is doing. So maybe we're either double working or we're totally missing the boat for people. So if like we could all see what each other is doing, like if I could log into someone's chart and be like, oh, Amanda's doing this with this person, I can follow up in this direction because now they're in front of me, like would be hugely, hugely beneficial.
Yeah, we're missing some of the care coordination piece. I think a big part of my job when I was doing outreach was just calling all the people, all the providers, like, and being like, okay, here's what I know about this. What do you know? And like, okay, I'll make sure everybody knows the thing, like being that connector piece. But like Ashley's bringing up, that charting takes a lot of time and just calling everybody. But yeah, some kind of
phone calls,
connection.
because like half the time when I call SDS, I'm on hold for 18 minutes before I actually get the receptionist. And then I'm leaving the actual case manager a voicemail. And then it's like days, like there's just like big gaps in care. And like, especially our unsheltered population, like I need to know the thing right now while they're sitting in front of me. And I never know that information. So I just feel like we're all like flying blindly. And if I could see what other agencies, what other community partners are doing, like would make huge difference in the work that I then do with them, right? Like So I think that's a huge barrier to getting services and care for our people in a timely manner. Like maybe I'm calling, making a Medicaid intake request, and they already have one, but I have no idea, and I'm just leaving voicemails, and nobody calls me back for 5 days. And so it's just like circles, I feel like, all the time. This is why hospice only bills for social workers doing phone calls, because of how much time we spend on hold on the phone and how much time we spend on the phone with people. So it's the only discipline that gets billed and per Medicare for hospice is because of how much of this legwork that we're spending our time doing.
And I also think medical needs to be tied in like with HMIS, like that would be ideal because the HMIS is the homeless management information system. They're tracking where the folks are getting social services. And I always thought it'd be so nice to connect those things because sometimes we were just looking for them on the medical side and then, you couldn't access that system.
This is Dr. Foster. I definitely agree there should be more connection between the medical system and all the social determinants of health system that's out there. But even within the medical system, I couldn't do half of what I did on a street medicine clinic without being a Peace Health employee that has access on my phone to Epic. But I can tell you there are organizations out there. I've heard stories where people doing volunteer street medicine have been told by their hospital organization, you will not access Epic or whatever it is while you're out on the street doing this free care. And they'll argue, but it prevents the person from coming into the ED. I have heard stories at national conferences of people being called and told you will not use Epic while you are working outside of our system. Luckily, I'm able to do that. I haven't got into trouble yet. I've gotten some phone calls, but usually I can say, well, sue me, or something, and they've backed off, but it's amazing. Even within the medical part of being able to see what's going on is limited, let alone the bigger picture of everything else we need to see to provide holistic care.
And I think that just kind of speaks to the fact that we need people like Dr. Foster with this power and privilege to be chipping away at this system a little more. We need more folks.
Yeah, I mean, don't we all rely on our backdoor connections? Don't we all rely on our networks or hitting up our homie who works over at St. Vinny's?
That's the only way we can do this type of work with this many care
Totally.
gaps. We need to be in community and network with each other because there's no way one case manager, one social worker can just fix all the problems, whatever.
And to speak on what Trevecca is saying, we're absolutely duplicating services. Absolutely.
Yeah, it's constantly phone a friend all day long in my world. I'm like, which bestie am I calling right now? Like, I love to hire new social workers. I do a lot of interns and then hire new social workers. And the number one thing I teach them is that this entire work is about relationship building and not burning bridges. And you better save names and phone numbers because you are going to need to phone friends all day long. So whether you like them, whether you think they were rude, whatever, like you better save their number and just be polite because you will need that person at some point in your career. It is a phone a friend world out there.
And if I've ever talked to you on the phone, I have your number still in a giant document on my computer. If I've talked to you in the last 10 years.
Well, I just want to be cognizant of our time. It's about 6:16. I did notice there is a question in the chat about Connect Oregon. Is anybody able to answer that question about how that works in connection with other systems?
And to Joel's point, like that was the one I was thinking of. I feel like I see this one touted as like the be all end all, but I haven't used it. I'm just curious what other people's experiences are. But it's that kind of thing where it's like just being able to see the map is like the success. Maybe not a lot of uptake yet. Maybe not. I don't know.
Yeah, no is always an okay answer.
I was just going to say that Connect Oregon is not something that we currently use in our work. It is something I would be very interested in looking into just for the sake of the opportunity of bringing to life what we're all talking about, creating bridge of care gaps and better service provision and more cohesive um, service provision and medical access for folks.
Yeah. Yeah, absolutely. It looks like it was built, Brenda says it was built by a veteran for veterans. So awesome. Yeah, very cool. Well, as we wrap up, I just want to give tremendous gratitude to all of our incredible panelists for being here tonight, and we appreciate everyone who attended so much. Thank you for being here on a Wednesday evening. It wouldn't be a great meeting without a call to action, so we do have a few actions for you to consider. We're going to be hosting another webinar discussing the intersection of faith and healthcare in early March. Please keep an eye out for that. If you haven't done so already, please go to hcao.org and join the movement. Adding your name to a statement of support helps add to HCAO's list of supporters and shows their strength and the popularity of this grassroots movement. You can also become a member for as little as $5 a month or $30 a year. HCAO is 90% funded by individuals like yourselves, and every dollar goes towards organizing and advocacy efforts. We're dropping some links in the chat. Whether you're interested in volunteering and organizing events or serving on a board, HCAO also has a ton of volunteer opportunities, so check out the volunteer page on the website. You can volunteer from all over the state. There are events on Healthcare for All Oregon's website as well. We also have a link to a survey. It's our first time doing this, so let us know what you thought about our session tonight. Also, let us know, what you'd like to learn more about. And just thank you so much for making this such a wonderful conversation, everybody. This was awesome. I learned so much.